So I just want to take a moment to thank every single one of our sponsors, and of course, maybe a moment. Yeah, thank you. A round of applause for that. And all of our speakers, moderators included, administrators and team. I see Rebecca in the back here. Raise your hand just for a second, Rebecca. Rebecca Hartman. And Riley here as well. So, you know, this would not have been even possible as an idea, as I said about a year ago, we kind of came up with, and I mentioned it, and I was like, yeah, let's go ahead and get this going. And I hope that it is worth your time to give us your Sunday. I mean, it feels that way to me, and I'm honored that you all have decided to be here. And, you know, showing your love to the sponsors, of which, as I said, this would not have been even beyond gotten off the ground. So for what it's worth, I just want to thank all of you. So let's see who has earned the right to bring and take this. The winner is Jonathan Solomon. This is unbelievable. Unbelievable. Thank you all. You are so kind to do this for me. Okay. Yes, sorry. That is just cheap laughter. I'll take it. All right. Michael Weitz. Raise your hand.
Who's the first one here?
That's pretty good. The first guy that walked in the building today. Yeah, again, what are the chances? Yeah. Well, there you go. Enjoy. Well worth it. Yes, get over here. Hold that, because I'm not going to do it. Yeah.
You got him? Over there.
All right. Andy, you got to run up here. Yeah, come on, get up here. As I said, we can't have him hold this. Sonny, get up here. We got to hold this up for him. And quickly. It gets heavy.
Oh,
Yeah. It is, yeah. It has the new generation excimer laser. Look right at Melissa. There you go. He's the winner. All right. Thank you. Yeah. All right. We are going to... You are. Just a second. I'm going to hand the stage, the podium that doesn't exist, off to, once again, our fearless clinical director, Dr. Weigel. Jen Weigel is going to give us the last session, because what is a conversation about refractive surgery without a discussion about post-LASIK or post-refractive ectasia? And I hope the answer is nothing, because we're doing our best to wipe it out. But we have to at least have that discussion, as it is something that is of value. So I'll give you the stage, and then you'll let us know when you want us back for the presentations, case presentations.
Fabulous. Probably when I get to my last slide, I'll want you guys back. So this is called ectasia. I call it ectasia because it's really icky. I really don't like having patients develop this, but this is about how do we detect people that have it, and how do we detect who might be at risk for it. So just remember, Dr. Solomon's referred to this before, that in a consultation we have twofold goals. One is get people that are appropriate candidates for surgery to have surgery, and then also if you're not an appropriate candidate, exit them out nicely, right? Nicely. Sometimes I'm nice. All right, there are different ways to detect detect keratoconus that Dr. Holzman had touched on before, so all the diagnostic tools that we have. And don't forget the power of your patient in discussion. Sometimes they don't recall family history, but when you're talking to them, they start thinking about it. Also, your contribution, knowing the whole family. We only know one family member sometimes. Sometimes we know families, right? But when you know information about the parent, you can tell us that information. That actually helped us one time, where the patient was like 20, didn't know that his parent had keratoconus, but the doctor told us, and that really saved the patient. Saved our butts too, right? So just a reminder, rubbing can change anything's structure, right? So these are just everyday examples of things that can change structure based on rubbing. Eyeballs are the same way, okay? So careful to note that allergy type eye rubbing is different from keratoconic type eye rubbing. So the keratoconic will rub much more aggressively to a much deeper and a longer duration, and they do it for the enjoyment of it. It gives them satisfaction, which is different from allergies. Allergies like, oh, rub, I don't itch anymore, good, I'm done, right? But then much deeper for keratoconic patients. Also, not discounting the sleep patterns, right? This is a favorite question of Dr. Solomon's, the patient, right? Is how do you sleep? Because when you're sleeping and you're hugging your pillow or you're digging into your arm, that's long duration pressure on that cornea. in a very consistent manner, and that can cause changes too. We've all seen this photo of the eye rubbing on the MRI. That's kind of cool. All right, so these are just some case presentations of people that have come in for consultation. How do we detect who shouldn't have surgery? Right, so this is a 46-year-old orthodontist. So this is a medical professional that does not understand why his right eye does not traditionally see well. Right, he knows it doesn't see well, but he's not quite sure why. So we scan everyone, right, which is kind of cool for me, right? I don't have to do a lot of the sniffing around for information like you guys do. But from his Panacan, we get a surprise, right? He has keratoconus in his right eye, and that's why that eye cannot see well. He doesn't know it yet, okay? So this is kind of an interesting discussion to the patient where they come in thinking that they're going to have LASIK, and you have to turn it totally around and say that you have a medical issue, right? And it gets even more interesting when they have a consistent eye care provider. It's very easy if they are skipping around from doctor to doctor. I've got an easy explanation, right? But if they're going to someone consistently, we have to word our words very carefully so that it's not to be like, it was overlooked. Okay, because that's a fine line there. But this person has not gone to anyone consistently, so I get to be a little bit more free with my verbiage, right? So his Bellins, which are the normative database comparison, will support the fact that we have obvious keratoconus in the right eye. And then, maybe histologically, the left eye is a little bit different, even though it's not showing topographic changes, right? The epithelial thickness map is going to support the diagnosis of keratoconus because you can see in the right eye, there's that localized thinning of the epithelium right where that cone is. And we go back and look at some history. He only has like 2022 and 2024 to compare to, but he actually looks pretty stable, which is consistent with his age too, being in his 40s. So thank goodness he's stable. So what do we do in this type of situation, right? We're going to confirm the diagnosis of keratoconus, right? Because the patient needs to know what's going on in their eye. Confirm that at this moment they're not doing LASIK and PRK because we don't quite know yet if they're stable or not. Right? So we have to remember that was their goal. Their goal coming in was to see if they're a candidate for LASIK or PRK. Address that, right? Also address the fact that they're human. When they figure out that there's something wrong with their cornea, that having keratoconus is not going to limit them in any way from achieving their life's goals, and also that they're not going to go blind because that's what they're wondering. And if you don't address that, they're not going to listen to anything else that you say. Right? This is especially important for pediatric patients that might come in. Let's say you send them in for scans, right? So we'll do that for your patients, and we confirm the diagnosis of keratoconus for them. They're like, am I going to graduate high school? Am I going to go to college? Am I going to have a job to be able to support myself? And yes, I do like to remind them that Steph Curry was goating before he even knew he had keratoconus, right? So they can still achieve their goals. Very, very important for them. Educate more on keratoconus, go do some research, and then no eye rubbing. Like nobody in the family eye rubs. Okay? If they have siblings that are local, they can come in and get scans. If they have kids, their kids can get scanned too. So he actually brought in his 3 kids, and they all had normal corneas, thank goodness, but we can follow periodically. You can do a poor man's cross-linking at home, which is oral riboflavin and some time out in the sun, which I think is helpful also because it reminds them on a daily basis that they have something going on. Otherwise, they get busy with life and they kind of forget that they had keratoconus, right? So that's how we get patients where we diagnose them and then they forget. They come in like a year and a half later, like, oh, I forgot I was supposed to come in. Like, okay. But if they're doing daily things that can help them remember. Come in, see if you're stable. If you're stable, then maybe we can think about cross-link versus not, maybe CAIRS, CAIRS versus not, or maybe ICL or RLE for patients. Okay? This is a presentation of a young patient where her refractive data is just not quite adding up. So Ann and I worked on this case together. So it's a 20-year-old, so the younger they are, the more careful we have to be in our analysis of the patient. Pretty much everything in terms of the eyeball is stable, but she's not able to see a sharp 20/20 like I would expect most 20-year-olds to be able to see, right? So her scans actually look beautiful, right? Her Bellins support that they are beautiful, and her epithelial thickness map looks fine. We go and find some history, and we can tell that in that refraction, we don't have that much history, only going back to 2024. Sometimes patients consider refractive history to be like last week. which is technically history, but it's not what we're looking for. So I'm grateful to have this. And the sill is kind of increasing, especially in that right eye, and it's kind of wanting to be oblique a little bit. So those are things we're looking out for, right? And again, we're paying closer attention to this because this is a 20-year-old. I almost said pediatric. I know she's an adult, but she's 20, right? So what are our concerns here? We've got a young patient with increasing cylinder, kind of that oblique axis, decreased BCVA, without anything that can really account for this, right? So in the context of doing elective corneal surgery on such a young patient, we're going to say, maybe it's not the best thing to do surgery at this moment. Maybe we wait and follow to prove that that cornea is nice and stable, that you're not going to develop keratoconus in the future. So in the discussion with the mom, I'm mentioning like, oh, irregularity, right? Because that's a word maybe she would know. Don't want to create it. Maybe we're too soon to detect it. And the mom says, oh, I was diagnosed with irregularity last week. Like, okay, what are the odds, right? And so I kind of almost don't believe her, but like, go get a scan, okay? So we have her scan, and then she has post-LASIK ectasia, so which is like, I would totally never have thought that. Her AR is like -17, -450. Crazy. So that confirms that we were, even without the mom's history, that we were on the right track to try to say, let's be the most conservative that we can be with a 20-year-old. We've got plenty of time to introduce her to refractive surgery. But right now, the most conservative option being that conservative nature. And then here, so just wanting to be really careful, told her, don't eye rub, don't create any problems, come back periodically. I do want to ask our surgeons, when the patient comes back, this patient comes back when she's like 25 or 35, what kind of procedure would you consider for her? Would you consider LASIK? Would you consider PRK? How about ICL? For what reason? Use your microphone.
If you're worried about her rubbing and having an irregular cornea going forward, at least I know with an ICL, that's not going to adversely impact that.
Yeah, I think that could be the most conservative option for her, and her prescription is definitely in line with it as well. So this is our last case presentation for our ectasia lecture. So this is a patient that had LASIK at another office in Florida. Okay? So the reason why I have 4 keratometry readings here for his right eye is because they did 4 different scans on him, and he got 4 different results, which a normal cornea should not have that much variability on a Pinacam. I mean, with every single measurement, I'm going to fast forward to these. When you sit down to scan, there is measurement variability like there is to everything. But they should get approximately the same scans in terms of like gross anatomy. But here you've got 4 different, like the central pack is like all over the place in this. So there is some indication that this eye is a little bit different. And then he discontinued contacts and ta-da, they're like more symmetrical. I don't think that contact lenses alone could account for why this scan looks good and why there was so much variability on the other ones. So I think they only took 1 scan at this visit, right? So he has LASIK with Intralace and Visex. He does day 1, they find DLK, they follow up with him in like 4 days, and it's like 95% resolved, and they're like, hey, come back in 2 to 3 months, which is kind of odd for me. I think you'd want to see that to resolution. And then they said, after that visit, they're like, come back in 10 months, right? So they're a little bit more liberal with their follow-up visits, and of course he no-shows to that, because that's how life goes, right? A couple years later, he goes back to the same surgery center complaining about his vision in the right eye not being as clear as he needs to be to pass a DMV exam, right? So they measure his refraction, and you can tell the magnitude of the sill is almost exactly what it was beforehand, but now you've got this oblique sill, right? So like right off the bat, especially if you're working in a surgery center, like that should mean something to you. That should mean you need to dig further. But do they do a topography? No. They don't. They could have solved the mystery right then and there, right? Instead, they diagnose him with dry eyes, and he's going to do warm compresses. It's awesome, right? so a couple years later, shockingly enough, because no one has intervened before, his sill is getting worse. Now he's got 350 sill, definitely oblique, with decreased best corrected to 20/40. And he actually sees a fellowship-trained cornea ophthalmologist in Northern Virginia. And do they do a topography? No. Right? So I don't know why. They should. So instead, they say, go do contact lenses. Great, right? And then he goes to see another optometrist, kind of the same story, right? But this person said, maybe you should go see a surgery center and see if something's wrong with your eyes. So he finally gets to us, and we did a topography. Go us, right? Because we scan everyone. But anyway, so he's like, now he's 20/80. So you're going with someone that was 20/20 at the beginning of his ectatic process, and now he's down to 20/80. And now somebody is going to be able to tell him that something's going on, right? So now he's got almost 5 diopters of still. Okay? So we do a pen and cam, and then he has post-LASIK ectasia, right? And this is the reason why he's having these persistent problems with his vision, with that decreased best-corrected vision, with that still, with that oblique axis, right? So now you have a lot of explaining to do. Even though we are not the ones that caused the issue, you still have to explain a lot to him. So avoidance of eye rubbing, explaining the process, need to have cross-linking, right, to halt the progression. Noting that it's not to take away the changes that have already happened. It's merely to halt the progression, right? And then this is the important part, is that this patient starts to call, email, and text me and the staff multiple times a day, aggressive presentation and increasing aggression, right? So now I'm like, I don't even know if I want you to be a patient here, because you'd probably be better off at another office. You'd probably be better off with epi on cross-linking, right? So I tell him, either you change how you interact with us, and we'll try our best to change too, right? Or I'll help you find someone else, right? So we helped him find someone else, and that was really relieving. No, I didn't send him. So I didn't send him to anybody in this room, thank goodness. But I think that's actually a very important discussion point, that even though your patients are interviewing us, we're doing our best jobs to always be as good as we can in interviews, but I'm also interviewing the patient. Do I even want to spend the rest of my life with you? I don't know. Not like we're getting married, but actually going to spend like a year together, right? And I need to know that you're going to be compliant. You're not going to second guess everything that we're doing, that you're going to have nice interactions with people. Okay. So anyways, these are ways that we can use the data that we're gathering to try to say who should continue through the surgery process to have successful surgery, or if you're not a good candidate, how can I kick you out in the nicest way possible? Okay. Any questions?
Who did we send them to?
Nah. I did not fall for that one. Okay. All right, Dr. Holzman's going to come up and talk about changes or with corneal cross-linking.
That was a good segue into what I'm going to talk about, because ectasia has been something that we've worried about as refractive surgeons forever. And it now, with corneal cross-linking, I won't say now, but for the last decade, we've had sort of a parachute with ectasia. So we know that if we even despite all the wonderful scans we do, and as careful as we really are, there could be one that slides through somehow. A patient develops ectasia, they rub their eyes and they develop ectasia. And at least now we know that they're not destined for a transplant, that we have something that we can do to help them prior to moving on to a transplant. It's a nice intermediary step. Interesting. Where's that? Oh, here it is. And corneal cross-linking, most of you know, and you've probably heard 20 at least CEs about this, especially if you live in Maryland. So it's been around from the Dresden Protocol was in the early 2000s. Okay, we didn't get it approved here in the United States until 2016, during which time there was a lot of studies being done. In fact, John and I were involved in some of the earlier studies trying to make this procedure faster and easier for patients. Because while it's a wonderful procedure, and it really is, it has its warts. There's no question about it. We have to take the epithelium off. We have to hope the patient heals well. They're going to have some discomfort. We've kind of modulated the discomfort pretty well over the last few years, figured that out. But still, it's not going to be comfortable for them. And it takes a lot of time. So it's kind of a drag for the patient, and it's a drag for the surgeon. All right, because the procedure takes 30 minutes to load the riboflavin. So we use 0.1% riboflavin for 30 minutes on the eye. Every 2 minutes, patient laying there. And then after that, we're going to hit the eye with the UVA lamp for another 30 minutes while we keep hitting the eye with riboflavin. Now remember, this is the FDA-approved approach with epithelium off. And then the patient, we look at the patient goes home. They wear a bandage contact lens. They typically heal within 6 or 7 days, as long as there's no healing issues, and then we go from there. But it's not, it's not as easy as we'd like it to be. So researchers over the last 20 years have really worked hard on trying to make this an epithelial-on treatment, and to make it more efficient, faster for both the surgeon and for the patient, and just more comfortable in general. And it's been a while. I mean, I used to think of cross-linking with epithelium on as sort of like showering with your clothing on. I was like, I couldn't imagine how you're going to get the exact same result with the epithelium on, which is a huge barrier to oxygen. And it turns out that, that's the big issue. If you look at this slide here, there's an equation that's really important in cross-linking. It's fluence, which is the total amount of energy on the eye, is equal to the intensity of the laser or the UVA lamp that we're using times minutes. So you think, okay, let's decrease the minutes. All we got to do is increase the intensity. And that's actually the studies that John and I were involved in. Just increase the intensity and drop the amount of time. Turns out it didn't work. Okay, it wasn't really effective, and the reason is because oxygen is being utilized too quickly. So the oxygen concentration was dropping too fast when the intensity is too high. So when you increase intensity, the oxygen drops. So, and epithelium, on top of that problem, epithelium is also a barrier to oxygen. So the answer is somehow supply oxygen to the cornea, and there's only a couple ways to do that. You could do it with oxygen goggles, potentially, or you can pulse the treatment so that it's not constant. So you give in between the pulses, you allow the oxygen concentration to increase again, so that the chemical reaction that's occurring in the stroma can be effective. So just looking at the role of oxygen is really, really important, and we have, as I said, the epithelium off approved in 2016. The good news is epithelium on is going to be approved next week. Okay, next week. We're pretty certain, and within or maybe a week and a half. It's most likely going to be approved next week, and that's a huge improvement. Now, it's not going to be rolled out for us right away, but it'll be rolled out probably in the spring, and it's going to be called Epioxa. And here you see a picture of the oxygen goggles that it's going to be utilizing. It's also going to utilize a proprietary formulation of riboflavin. And I believe it's also going to be using pulse treatment. But it's going to be increased intensity, and it's going to be faster. So the whole thing is going to take 20 minutes versus basically an hour and a quarter. So everything is going to, and the patient is going to be way more comfortable. So post cross-linking with this, the patient will probably have a bandage contact lens, because still there's going to be a little bit of a sunburn on the cornea, probably for a day. It might not be that bad, but probably a bandage contact lens for one day. And maybe even we might be able to do bilateral cross-linking in the same day. Okay, so it's going to make things much easier. And we probably are not going to have to wait for the progression of keratoconus to go ahead and treat. Okay, right now, I mean, the FDA wants us to wait until we show progression. It's like waiting, okay, let's wait until the patient loses vision, and then we'll do a cross-linking. That's kind of where we are. And I find that approach ridiculous. So I would rather go ahead and there's ways for us to get around that. I mean, if you look at some of the historical data, some of the doctors will send to us, and they'll say, well, the patient was 20/25 or 20/20, and today they're 20/20 minus. That shows me progression, so we can go ahead and do it. So there are ways to get around that, but it'll be nice to be able to just do this at the time of diagnosis. Not that epithelium off is bad. I mean, it's a 97% or 96 point whatever percent efficacy, where we get either topographical improvement or stability of the topography with epi off. So it's a really great procedure, and it gives us about a 1.7 diopter flattening of the cornea. But again, the bandage contact lens, the healing issues, et cetera. So we really are looking forward to the Epioxa. And just to go over a couple things for healing, if you ever do co-management of cross-linking with us, we tend to keep the patient, honestly, until the epithelium is healed, unless the OD says to us, please, I'll see all the post-ops, which would be unusual. And certainly, though, if you're up for it, we'll be happy to send you those post-cross-linking patients, and then you can see what we're dealing with. But we typically wait until the cornea is stable before referring the patient back to you. There are some nuances about putting that much UV light on a cornea. It definitely slows the epithelial rate of healing. We do not use mitomycin during cross-linking. We use mitomycin during PRK. They're both UV lights, PRK and the UVA for the cross-linking, but they're different wavelengths. And the PRK, of course, is only on the cornea for probably about 10, 20 seconds, whereas the UVA light, a cross-linking lamp, is on there for 30 minutes. So there's a lot more that goes on, and we have to be cautious with patients who don't have good systemic health, older patients, or patients who have really, really bad cones. Because the patients who have really bad cones, very steep Kmax, those patients tend to heal slower, and sometimes we can end up with a non-healing epithelial defect, which can be a very big drag. We can also, if you see cross-linking patients maybe 2-3 months post-op, you're going to see corneal haze. It's not out of the ordinary at all. It's normal. The good news about the corneal haze and cross-linking is that it's self-resolving. Whereas PRK corneal haze is more anterior, it's more disorganized tissue, and it's not self-resolving. And for that reason, we use mitomycin when we're doing PRK treatments to decrease the risk of corneal haze formation. Whereas with cross-linking, we just look at the corneal haze, notice it, and realize it's going to go away. And there's very likely to be some corneal haze still with epithelium on, but not nearly as much. Okay, so the idea is that there probably will still be corneal haze, but it will be self-resorbing. So here's a case presentation of a 29-year-old who went to an OD locally, was seen in 2021, I think that says first time, and diagnosed at that time, but didn't want treatment. So they just said, well, let's just follow it and see what happens. Apparently, they were asked to have treatment, but they declined it. So you can see here on the left eye, over the course of 2 years, the patient went from -2.25 to 350 in the sill. The axis changed. The visual acuity dropped from 2020 to 2025. And this is just because we're watching it. We're waiting for progression. And here we had it. And so you can see the Kmax differences between the right eye and the left eye. And the right eye is more normal. The left eye is up in the 50s. The right eye, this was the initial presentation on the pentacam when the OD first saw the patient. And we first saw, did we see this patient in 2021? No, good. So this was an initial pentacam. And then just 2 years later, this is the same patient with the cone, as it's obvious. You see the cone down there. And the elevation maps are all off. And you can see compared to the normative database, everything is lit up red. And this is a little bit better view of it. You can see the Vario, which is the topography I was talking about earlier in the day, which gives us a little bit more information about that cone. But this patient has an obvious cone. The epithelial thickness map is there, abnormal in one eye and not the other. And here you can see the ZOTAP, which is on the left is normal in the fellow eye, and on the right is the cone with the severe coma. So sometimes we run into these. This is not a typical case, but this is a typical case of a problem. Let's just say that. So let's say you have a problem in healing. This is what it might look like. Here's the epithelium off. You see that little epithelial defect there on the right of your slide. That's on the right of your slide, correct? Yeah. What's that? Yeah. And it's coming together, but the edges, this is something that anybody that co-manages PRK should also be aware of. Sometimes when epithelium comes together after PRK and we use mitomycin, the edges are sort of necrotic. The epithelial edges are necrotic, but they're moving forward. And then when we get to the middle or close to the middle, it's basically dead or sloughed sort of epithelial cells that are clumping together in the middle. If it's like this, it's not good. It's going to disturb vision, and it's going to potentially fall off and cause pain. So, we watch it for a while, and we use Muro, and we'll put bandaged contact lenses on, and we'll try to get that to heal. But after a while, I just give up, and I just take the dead cells off. So we do a debridement, and then this was about a week or two out. And then once we debride it, the epithelium heals and gets better. You all can do this in your exam lanes, believe it or not. It's not outside the scope of your practice, or is it, Jen?
You do it.
You would prefer that I do it. Okay, but it's really not outside the scope of your practice to be able to debride dead cells off of an epithelium. If you can definitely do it, and it's obviously quite effective. That's the end result there. And this is a patient who had epithelium off cross-linking in 2023, had an excellent result, excellent outcome. You can see the before and after. They don't look anything different. The patient's stable as could be. And the question here is, what do we want to do with this patient? Do we want to now go, because the patient comes into us because they want to have LASIK or they want to have PRK or whatever they want to have, and they want to see better. So we find keratoconus, we do the cross-linking, and now, they still don't see that good. So what are we going to do with them now? Well, there's a couple of things we can do with them. One of which is topography-guided PRK. And, I've been doing this for a while, and you can do topography-guided PRK at the same time as you're doing the cross-linking. That's called the Athens protocol, first developed by a Dr. Kanelopoulos, who works in Athens, and described this technique, and, we've used it for a while. The problem with doing it simultaneously, there's a couple problems. Number one, you're doing a PRK and a cross-linking at the same moment, and the epithelium is really disturbed. So you could have more healing issues with that, okay? The other issue is that cross-linking in and of itself creates flattening on the cornea. And it can be progressive. So in the first 6 months, you're seeing some flattening, maybe continues. We've seen some cases that can continue over the course of several years, flattening 2 diopters, 3 diopters. So if you're doing it simultaneous for a refractive result, you may not be doing the patient a world of good, okay? Because they're gonna over the course of time, they're gonna flatten. Or you can do it post cross-linking, which is kind of the way I like to do it now, which is where you do cross-linking, wait 6 months, wait a year, 2 years, look for some stability in the result. This is a patient that had cross-linking here. And then we went ahead and did topography-guided PRK on them. We don't like to take a lot of tissue off. I only like to limit it to around 50, 60 microns of tissue, which is usually enough to flatten the cone and steepen the area around the cone. So remember, we're flattening one area and we're also steepening the area around it. So it's sort of an additive thing because it's a topo-guided treatment. If it was just regular PRK, everything would flatten, including the flat area. Okay, so it's, whereas this is a better treatment, and it's usually enough to give the patient the ability to wear soft contact lenses. Sometimes we get lucky and we get a result like this, which ends up being 20/20 uncorrected in one eye and minus 50 in the other. So, there's things that can be done with a laser post cross-linking. I think Dr. Siddiqui is going to follow me and talk about intracorneal segments, which is a really exciting thing that we're going to be starting ourselves as well, for more severe cones that can really help reshape the cornea. But visual rehab following cross-linking is a real thing. I want everybody to realize that. It's something that we think it's really important for these keratoconic patients. And I think that's it. Oh, no. Can keratoconus progress after cross-linking? Yes, it can. We've seen several cases, but the literature tells us it's 5%. So 5% of patients after cross-linking will progress. Who is it that progresses? It's the young patient that rubs their eyes, okay? Or the high high K-max, the bad cone that rubs their eyes. So I tell all of my patients who are having cross-linking, listen, you cannot rub your eyes. And some of them are just addicted to eye rubbing. I mean, and you just have to somehow break that cycle. You have to tell them literally you're going to blind yourself. And, and these are 16-year-old kids, and they'll listen, when I say something like that, they'll, woof, I haven't rubbed my eyes since you said that, doc, and so sometimes you have to just be blunt with them, because just don't rub your eyes. It's like telling somebody, breathe a little slower, or, blink more frequently. I mean, it's not something that is easily transmitted. You can say it easily, but it doesn't, nobody really listens to you. And so this is just the case here that the patient was diagnosed at 14, had cross-linking at 16, and this is what he had at in 2022. You can see on the left and on the right, this was after cross-linking. So you can see the progression there. And his fellow eye got worse as well. So the fellow eye, which is, of course, keratoconus is asymmetric. The fellow eye wasn't so bad in 2022, and then here we are in 2025, and he's definitely developing a cone. So this patient needs bilateral cross-linking. The question is, should we go ahead and use epi-on cross-linking for his repeat treatment, or should we go back, take the epithelium off, and do what we know is clearly effective on the second trial, on second time through? And honestly, I don't even know the answer to that question. So if anybody does, please tell me. Any questions? I think that's all I got. Any questions? Yes. Yeah. Yeah, that's definitely something we would do. We've used amniotic membranes for that. I mean, this was a couple weeks out, and it was a very small defect, and we thought it was going to close. So, and it was, you can tell that the edges are necrotic, and all you got to do is take those dead epithelial cells off. So it was kind of easier to do than than the amniotic membrane. But if it's a bigger defect, that's absolutely in the cards. Amniotic membrane for sure. Yeah. Anything else? Okay, thank you.
Off, Andy, sorry, before you go. So let me ask it a different way. You have a patient that's 20/20 correctable with a contact lens. I'm just throwing numbers out. 20-year-old young man does the eye rubbing and the pillow hugging, the whole deal. And he is correctable to 20/20, okay? And he comes in for refractive consultation and you say no. Would it ever be a scenario where you'd say, no, you have this illness that's likely to get worse. You're not a candidate for LASIK, but go ahead and continue to wear your contacts? Or is that, maybe I'm leading you here.
So you're telling me that he has keratoconus?
Yeah.
But he's 20/20 in a contact lens?
Correct.
What would we do? Well,
Yeah.
we wouldn't treat him. We would follow him, really. We would tell him that we're going to see you in a year or so and see if this is progressive.
But he's 20. He's 20. And so I'm going to call you out. He's 20.
Okay.
You know he's going to get worse.
Okay.
Statistically.
Well, depends on what kind of cone he's got, right? So if it's just form fruste, we usually say 6 months. If it looks like form fruste, it looks like, we'll go 6 months for follow-up.
If it was your son.
If it was my son, I'd probably cross-link him right away.
So I think that's my point.
Hold on. This brings up another point. This is really important. A lot of patients see 20/20 in your offices with scleral lenses. There's a ton of them, right? You all have them. And a lot of them haven't been cross-linked. And a lot of them are getting worse without you realizing it. Under that lens, okay? So what I always talk to ODs about is like, listen, you've got a cone. I get the idea that the patient's seeing 20/20, but you should send the patient in for scans to see if this thing is getting worse, because it's the gold standard now is to cross-link these patients. You don't want to be the doctor that just keeps saying, oh, you're 20/20, you're 20/20, and we don't. And the cone progresses by 2 or 3 diopters, because the scleral contact lens might be masking that. So it's something that you really have to keep thinking about, just to get these patients scanned. Yeah.
I think also, we're used to the idea with, let's say, glaucoma, trying to detect it earlier and treat it earlier. Now with myopia control, it's like control it first, and now there's myopia prevention. So even identifying kids that have not yet developed myopia, but looking at their case, looking at their axial links and trying to prevent myopia, Keratoconus, same concepts here. We went from purely detecting it, then it's treatment of progression, stopping it from progressing, and then now what Dr. Solomon's kind of hinting at is like prevention too, right? Preventing that from getting to the point where it's causing any troubles with their vision, keeping their activities of daily living fully intact without having to suffer from any kind of vision loss. So just like the rest of the profession's gone from like identification, control, prevention, cross-linking exactly the same way, even easier to accomplish that goal with Epi-on.
No doubt about it. Epion's going to make a difference on that because the risk-benefit ratio for taking the epithelium off on a patient we're trying to prevent something might not be in their favor. Okay, so with Epi-on, I think it's going to be something that we're going to do a lot.
Can you also talk about how fun you think it is to do cross-linking Epi off on a 16-year-old?
Yeah, it's really a lot of fun. I don't know if there's a talk about blepharospasm in here. I think it's part of, But I think coaching, and it's a psychological game with people. It really is. People don't like things coming near their eye, especially young patients. And I know all of you, are ODs, and you have to do things near patients' eyes, and you say, don't squeeze, don't squeeze, don't squeeze. And it's really hard to say that for 30 minutes or 60 minutes on a 15 or 16-year-old. It's really very challenging. But I will tell you, the trick is, tell them to focus on their brow, okay? You need to tell patients, focus on your brow. If you tell somebody to focus on their brow, just give them that one task. Do not move your brow. I don't want your brow to move at all, okay? Your brow is dead. We've injected it with Botox. It's not moving, okay? It's like life or death. You're not moving your brow. They can actually do that. I don't care what, you try it with your next patient. Don't move your brow. And then all of a sudden, they'll let you open their eye. And people will say to me, nobody ever told me that. These patients have been, going to doctors forever. No one has ever said that to me. So I don't know. I think maybe it's a pearl. I don't know, but something to take home. Tell the patient, do not move your brow. Keep it flat. That's how you get them through blepharospasm.
And then they avoid Botox in the future because they never develop wrinkles. So there you go.
That's
Look
right.
at that. The Holzman technique. Again, I think if there is a final thought on this, if Dr. Weigel didn't make the point in a very delicate way, of those in the room, with the exception, I think, of Dr. Siddiqui, who's doing 90% of the grafts these days. Keep in mind, the CLEC study pointed out you have a 20% chance, longitudinal study of keratoconus, and that study is old. It's 20 years old. You have a 20% chance, if you're diagnosed with keratoconus, to need a transplant. And each transplant historically only lives to be 20 years. So if they're at 20, you graft them, they're now 40. The half-life of a transplant, when you have to regraft, is half the half-life of the original transplant. So now it's doing it again at 50. And so it's not, in my mind, inevitably, I was sitting in this room 15 years ago as part of the recruitment process for the Avidro study, of which Andy was talking about. And honestly, I just gave this, what I thought was super cool lecture on how we're going to slow down keratoconus. And I had a doctor come up to me as I was walking out of the room. He's like, you're not going to believe this. I had a patient that had horrible keratoconus, and I fit him in a scleral lens, and he's 20/20. And I paused for 2 seconds. I was like, so are you going to send that patient in for the study? He's like, I guess I hadn't thought about it. And I was like, well, that lecture was worth nothing. My point in saying it is I agree with Dr. Weigel. I mean, you want to deal with epithelial non-healing? Yeah, it's a big jump to go from epi-off to epi-on. Deal with a dehisced graft in a 20-year-old who was playing in the library during finals, and they get poked in the eye with a transplant, and now their iris is coming through, just because they're doing what a young man does. And so who cares about a little bit of delayed healing? Again, I'm being facetious here and overly dramatic, but relatively speaking, if you can stop that cone, and you like that they're seeing well in 20/20, scleral lenses, toric lenses, soft lenses, still send them in for a consult. I don't care if they have to show progression. My point is they have the diagnosis. They are going to age. There's a 1 in 5 shot. That is truly Russian roulette. It's not 1 in 6. It's 1 in 5 they're going to need a transplant. And so if they're 50 and you got them in a scleral lens, maybe they're not going to progress. But if they're 16 to 35, to me it's not okay to say, or they're seeing well with a contact lens, we'll continue to monitor them. Nope, I can tell you, 1 in 5, they're going to progress. If it were my kid, that's when I said it, if it were my daughter and they were still 20 with a posterior float, no anterior corneal changes, maybe some subtle epithelial changes, I would absolutely cross-link her. And with epi on coming around, I absolutely would do it. I mean, these young people are miserable as they progress. And it's a refractive tool. The reason it's in this session is because just because they have keratoconus, I know we're not supposed to do LASIK, but you can refractively change their life with a minor surgical intervention. And I would encourage all of you, take the bull by the horns, make sure you let them know what's going on, and send them in. Send them in to just be evaluated at the very least and talk about options. So I'm done my soapboxing. There's a question. Oh, sorry. I'm sorry?
Do you have to document signs of progression in order to get coverage for customers?
So I do believe you need to document that at this point. What's ironic about all that is you did for the HDE, humanitarian device exemption for Intacs. When we did the FDA trial for Avedro, you did not. We didn't have to bring them back for that trial. Because as Andy pointed out, what you did is you had to prove that they lost vision to then try to get the vision back that they already lost, and you're not going to get it back. And so in many regards, it is worth saying that they're having progressive difficulty, contact lens challenges, okay, worsening vision, and last option other than that would be a transplant. So those are the 3 things that we have in our chart all the time. Worsening vision, contact lens challenges, and their only other option is to do a graft. And that's what keeps Dr. Siddiqui very, very, very busy with all kinds of clever grafts. And so he's going to talk to you about grafting tissue without taking tissue. So without further ado, Dr. Siddiqui, go for it.
So I'm talking about CAIRS, a new frontier in corneal surgery. And by the way, can I just say what an honor it is to learn from some of the refractive greats in this area, Dr. Solomon, Dr. Gould, Dr. Rivers, and Dr. Andy Hoffman. Holzberg, sorry. So CAIRS, a new frontier in corneal surgery. So again, no financial disclosures. Although I am an instructor for Lions Eye Institute to teach Natural and other grafting. So keratoconus, we're aware of this progressive bulging corneal disorder. The prevalence is 1 in every 2,000 individuals worldwide. So it leads to irregular astigmatism, distorted vision, contact lens intolerance. And traditionally, our options had been glasses, contact lenses, cross-linking. We just heard an amazing lecture on that. But how can we reshape and remold this cornea so that we can improve vision without having to necessarily have the patient wear scleral lenses all the time or perform a cornea transplant surgery? So we typically in the past, we'd been doing synthetic intracorneal ring segments, but they're associated with extrusion, infection, and melting. So that's what they look like. You can see that there's a PMMA polymer-based ring segment that we insert into the cornea, and the idea is to flatten the steep meridian and minimize asymmetry. And it's used to sort of contain and constrain the cone and reducing myopia. And typically it's within the 6 millimeter optical zone. And there are many different algorithms and nomograms out there that help us figure out kind of where to place these ring segments. But the idea is that they essentially flatten the cone. So here's a case of a 61-year-old patient complained of worsening vision at night for many years. So he's got stage 2 keratoconus right eye and a worsened stage in the left eye. Vision is 20/50 in the right eye, 20/40 in the left eye. But if you look at the refraction, they've got significant amounts of cyl in the left eye. So we decided to do Intacs for this patient, and this is a while back. And you can see the amount of delta. So on the left is pre-Intacs and on the right post-Intacs, and you can see how much the cone is constrained and limited due to the ring segments. So that leads us to talk about, well, what is CAIRS then? Is that basically Intacs? Well, it's similar. It's using corneal allogenic intrastromal ring segments. So it's using donor corneal tissue instead of synthetic PMMA ring segments. And it's implanted within the stroma after creating tunnels with femtosecond laser. And the goal is to restore corneal shape, reduce irregular astigmatism, and ultimately improve vision. And it was first performed in 2015. So it entails insertion of these rings using in the femtosecond channels, and it helps. It enhances the outcomes greatly because of its biocompatibility, and it's flexible. It's not a hard piece of plastic in your eye, so there's less risk of extrusion and other problems that can happen in patients with Intacs. I've seen patients in my clinic where, sometimes after, in a rare occasion, trauma can cause extrusion of these plastic ring segments. So you create these ring segments using femtosecond laser. The eye bank sends us donor corneal tissue cut into an arc-shaped ring, and I have a video to show in just a moment. And these segments are inserted into channels at about 40 to 50% depth of the cornea. And their adjustments are based on a certain nomogram, and it can be combined eventually with corneal cross-linking. So here's another example of a patient's eye, and you can see quite the distorted cone in this patient. So let's play this video. And so I just want to remind us to look at where the cone is. It's sort of inferotemporal in this patient's eye. So now we're sitting at the head of the patient. We're at 12 o'clock. And the channels, the femtosecond channels, have already been created. And you kind of lift up the edge of that channel, and you're gently inserting it. The analogy I like to use is you're kind of feeding through pajama strings. So that's kind of how you're just gently nudging it forward. And you have to take care that it's not getting bundled up, it's not getting twisted in the eye. You want to make sure that the insertion is nice and clean. And once it's inserted, it's almost like an earthworm. It has a little kind of it's squished together a little bit. So you want to put some fluid on the eye, press down on it, and just kind of squeegee out any compression within the ring. And one thing I'd like you to look at is the circle of light that appears in the center, and we're kind of using that as a guide to see how well this is already reshaping the cornea. And circular light reflex is a good sign that it's kind of doing, it's being effective already. And so in a moment, you'll see that ring of light. And this is, patient is awake, it's just topical proparacaine, and you can see how quickly the ring segment is in. So that's the ring of light. You can see how circular it just got within the last 30 seconds of starting this video. So pretty interesting way of kind of reshaping the cornea. So what did that do to the patient's cornea? Well, look at the topography map here. This is 3 months after the surgery, and you can see how much more contained the cone is after doing this. And you can see in this difference map, so on the left side is post, right side is pre. You can see the amount of flattening that occurred as highlighted by the blue and the third map on the right. So the advantages of CAIRS is that it's biocompatible, or it's natural collagen tissue that integrates with host tissue. It's reduced complications, lower risk of extrusion, melt, and infection. You can customize it however much you like. You can use various thicknesses, lengths, arc angles. There's an element of reversibility. You can take these segments out or exchange them. And you can you get better stability compared to synthetic ring segments. So within our practice, we did a study of about 100 eyes, and we found that the mean topographic diopteric reduction was about 3.45 diopters, and we reduced their manifest cylinder by about 4 diopters, and improve their mean uncorrected vision by 9 letters, and then best corrected visual acuity improved by 14 letters. So, and then 49 out of 57 had mean thickness of around 508, and 94% of the patients were successfully fitted with contact lenses, which ultimately enabled them better vision. 2 of those ended up getting ICLs, and 1 continued to get cataract surgery with a toric lens. Another meta-analysis was done of 14 studies with 442 eyes with keratoconus, where both the primary and secondary endpoints showed promising improvements in the corrected corrected visual acuity and uncorrected distance visual acuity as well. So, very promising surgery. So future directions, we would love to have more data and thus more standardized nomograms to help improve predictability. And then wider adaptation with more tissue availability would be helpful. And then integration with cross-linking. So, ideally it would be nice, depending on patient's age, you could cross-link them after you've reshaped their cornea, and or perform topo-guided PRK for combined effect. And this could potentially successfully replace the intact surgery we had been doing up to this point. So this is an exciting step forward. So again, CAIRS is a novel biocompatible alternative to synthetic intracorneal ring segments, and early results show safe outcomes, good stability, and just gives us more tools in our toolbox for keratoconus and ectasia. And it represents an innovative way of using donor corneal tissue in refractive corneal surgery, and future looks promising as more adoption grows. So thank you all so much. Wonderful.
Thank you.
Yeah.
I think my mic is hot now, so you two need to kind of figure this out. I'm going to take a poll for the audience here. Okay, you've had a great day, and we are so grateful for your patience here, actually, and your willingness to give us time. Who's got it in them to hear a few case presentations? Really? Yeah. Who? I mean, we have some really cool cases, everybody. Thank you. Thank you, Christine. I saw 1. So 1 means all. That's how I got 2. Yeah. All right. So indulge us for just a bit longer. We're a hard stop in 15 minutes. All right. Can we do that? That means we got to run. Sonny, you're up here. You're up here. Andy, you're up here. Come on. We're just going to be kind of the stump the chump. Okay. And so, Dr. Siddiqui, you're up here, all right?
Nobody wanted to hear this.
Everybody wanted to hear this, all right? This is where it's like I invite you to my house for Thanksgiving, and you don't get to sit in my living room. All right.
You have to have the dessert.
So,
Presentation, do you get to pick which case you want to have?
Listen, the commanders, by the way, started at 4. So we have plenty of time.
Somebody real quick, pick a case. Number 4. What is that?
4 p.m.
what do you want to see?
Oh, corneal scars. Can you
Corneal
press that
scars.
link, please? All right, so this is a patient that has a lot of corneal scars, and what do we do with that?
So set this up. This is a patient coming in for refractive consultation, yes?
Yes. Can you click?
There you
will
go.
it go on that link if you
keloid scar.
click that hyperlink? Yeah. No. Lots of corneal scars. I know we have so many scars on here, right? So it's going to come up in just a second, or can I just go through? Okay, I'll just go through. Anyways, geez, Louise.
That's it. Yeah, back up.
No, it's not.
This isn't it.
Let's just talk about keloid scars, okay? All right, so go back.
Stop.
Wow, this is like my driving.
There we go. That's
okay.
it. That's it.
Stop. Right, go.
It is.
It is?
That's okay.
Oh, you think I haven't been sitting in the audience all day? I would have gotten that, right? Okay, so this patient has a lot of scars. I think I still have to go back a little tiny bit. Okay, I'm getting too excited. Hold on. Okay, so 52-year-old female that wants to have corneal vision correction. She wears extended contact lenses because her son has special needs and she needs to be able to wake up in the middle of the night to take care of him. But because of that extended wear, she's got a ton of scars on her cornea. She's willing to use near vision glasses on top of her her procedure because she does that now with contact lenses. And then RLE for her is cost prohibitive. Of course, we do talk about all our options, okay? And it's not our job to predict what's in their pocketbook, okay? So she gets to tell me that. And this is kind of a normal presentation here. It actually would be consistent with LASIK if it weren't for the fact that she has so many scars. All right, I did test her corneal sensitivity because with so many scars there, at one point, maybe some of these inflammatory events might have affected her corneal sensitivity. Thank goodness it was still intact. And then she has like great topos, right? So even though she has these scars, they're all very superficial scars, not affecting the corneal topography very much. At that time, I didn't take a photo, which I know is very shocking to Dr. Solomon, but this is like my pictorial depiction, of her corneal scars. Got a ton of them, right? So I'm going to ask the surgeons, how does having a scar affect your ability to create a LASIK flap or a smile pocket? And then we'll kind of go from there. Dr. Holzman, your case.
Flap. Well, back in the day when we used rotating, oscillating blades, okay, this was microkeratome days back before 2004, this wouldn't have affected us at all. We would just cut the flap and it would be fine. But with the femtosecond laser, it's a problem because, and not always, but if it's a deep enough scar and the scar has, you can see epithelial plugging. So it's an excavated scar. So you can see sometimes an old ulcer or something that has epithelial plugging. And we're creating a flap at about 110 microns deep with very high pressure gas. And when the gas hits that area, in that area of epithelial plugging, there's a chance that the gas comes right through and pokes a hole in the flap, which then leads to problems. Vertical gas breakthrough. That's exactly right.
Does it create 99 problems?
Creates a lot of problems. So we avoid that. Sometimes we'll look at a scar and we'll say, you know what, these scars are kind of superficial. They're faint. I can make a thicker flap. I can go underneath this, and I don't have a problem with it as long as I make a thicker flap and the scars aren't too deep.
So why don't you dust off your microkeratome and just do a microkeratome flap?
Yeah.
So the other thing I have.
Well, wait a minute. So why?
We don't have one.
Okay, so we don't have one, and why don't you have one? Why don't you invest in the older technologies that could cut through it? Is that not an
Because
option?
if you don't use it
ridiculous.
regularly, you're going to have a problem with the technology.
Yeah.
You have to use it regularly so the staff's up to date on it. You keep it in good condition, good working order. You can't pull it out once a year and expect to have good results.
There's
with it.
other good options. You can do PRK.
You do PRK. You do smile on the left eye. If you go back a slide. On the left eye, because of where the scars are, my smile treatment is in the middle of the cornea.
Right.
Those left scars won't bother me at all. On the right eye, I would either do PRK or thick flap LASIK. Yeah.
Very nice.
So,
What about ICL?
yeah, would you do
Or
it?
SCL. Yeah, 100%.
100%. So you have options.
You have options.
There you
But
go.
not for her, because she says cost prohibitive. So that's why we did PRK on her.
PRK.
Yeah, and she's lovely. Every time she comes to the waiting room, she makes me something like a painting or something with a little bit of flair to it, and I have them in my office. So I did enjoy that.
That's nice.
All right.
She ended up 2020. Right?
Oh yeah, of course. All right, and then who else? Who wants to pick a? We only have 15 minutes. Somebody pick a case.
Patient with autism for 400, please.
Oh, that's a good one.
Are you able to click? Oh, very good. Thank you so much. Okay, these are two cases that we had for patients that had autism. So Now we're starting to see with autism being diagnosed more frequently. Now we're starting to see more patients that have autism that still want to have the visual freedoms that everybody else enjoys, okay? So just because they have autism doesn't mean they don't have the same wants or needs that we do, right? And I learned a lot from these people, actually. So this patient had autism. When he came in for his consultation, he was cooperative during the like the slit lamp and things like that, but didn't have eye contact and really didn't smile. But, you know, he can still get through the procedure, I thought. So consistent, his prescription's consistent with LASIK. He had the procedure. I did get educated by Dr. Holzman on this, that it was a very tough case. So share with people what was tough.
Well, it was probably a patient who couldn't, I can't remember exactly, quite honestly.
He had a lot of blepharospasm.
Yeah. So, you know, these are patients who require a lot of coaching. And, you know, being a refractive surgeon isn't just cutting and it's dealing with people and their mental focus and their ability to stay calm under pressure. And so it takes a lot of work, sometimes psychological manipulation for all of us when what we're doing. We don't want suction breaks. I'm sure you don't.
That's right. And what I'll do in these cases is invite one of the parents in to hold the patient's hand.
I think we did. Actually, I think we had some.
These are one of the learning points that we.
Yeah, we had a relative in the room. I believe.
So that was with LASIK, right? And then when he came back for his one-day post-op, he was able to maintain eye contact while he was telling me how great he was feeling. He was actually smiling. So that was a very different change in personality, and I think a lot of that comes from one, his enjoyment of his result, but also the enjoyment that he was able to accomplish a procedure that is tough for even like a more routine non-neurodivergent patient. We have another patient that also had autism, kind of coming in really closely behind this other one, that had a very high prescription that I thought might be more appropriate for ICL.
Perfect.
So this patient came in the spring. I said, you need to go and work on your blepharospasm too. Try doing lubricants. Whether or not he actually did, I don't know. He claims he did, right? So he comes in the winter. We get him ready. He's doing actually better at that exam, so I thought he would be good for the procedure. His PACs, well, no, that's too high of a prescription to do LASIK. But the topographies are nice. He's going to do, or planning to do, ICL with following up with LASIK because he's not able to address the whole entire prescription. So on the day of the procedure, Dr. Solomon is going to do kind of like a dry run, see if the patient can cooperate. And then?
Yep, so perfect example. And I also just want to pause for 2 seconds to, getting back to Dr. Holzman's point, because it, I think, went right over if we weren't paying attention. The idea of concentrating on your brow. We do the same thing. It's just keep your eyebrows up. You just don't want them squeezing down in some regards. A whole other thing happens with that. They usually open their mouth and then their head tips back. And so you got to be mindful of all of it. But it's keeping the body, low intensity is another thing that is being used. Keep the body at a low intensity procedure. However, we did our dry run, we tried it, we got to the draping, and he just was not able to keep his eye open or stable. And the decision was to just pause. There was no point in trying to push this through. He is doing this in office-based procedure, but also keep in mind we have access to an ambulatory center. You can start an IV. You can take him to an OR space where he will, pharmacologically be completely sedated for a short period of time in order for you to do what you need to do. So we are able to make this work, and I'll just emphasize this again. Just because we can doesn't mean we should, and this was not a scenario where we just pushed on just because we could go ahead and get a lid speculum in. I'd love to be able to offer him that. It just didn't make sense in our setting at that moment.
So I will say that these patients came in when they came in, I'd been working with Dr. Holzman since 2011. This all happened like this year. So even for me, I think, gosh, I know all these things. And then this was just such a new opportunity for me to learn. So what do? We recognize that patients with autism come in a broad spectrum. If you've met one, you've met one, right? And I start questioning patients. So when patients come in, it's a mom that maybe has a child that has autism, but the other one that is the consulting patient maybe doesn't. I'm still asking that mom, what are some things that I can learn from? How do I make this experience better for the patient, right? So the key is is we are meeting the patient where they are. We're not asking the patient to meet us, right? So how do we make this more comfortable? So having the parent in there, making it quieter. Dr. Holzman loves music, right? But lower the volume down so it's more pleasing to the patient. Lower the lighting. All of these things to try to make it a less stressful, less stimulating environment so that the patient can try to get through the procedure successfully. And I think that these are good cases that say that we're constantly learning and we're trying to better ourselves so that we can then turn that new learning around to offer these procedures to more patients.
Cool. Would you put a bandage contact lens in a patient like that who's squeezing a lot and potentially at risk for rubbing their eyes after their LASIK?
Post-op?
Yeah.
No. It's just so hard to take the contact lens out the next day.
But you don't have to do that.
Yeah, but that speaks
Well, I
to
don't have to do it, but
that's-
I know somebody's going to have a really hard time with it.
But it speaks to your your level of confidence also about the,
Right, the
the
flap.
stability of a femtosecond flap.
Yeah, exactly. I mean, it's just not common to see flap movement or stria these days. It really isn't. And it's because of the architecture of the femto. I was asked during the break, a doctor asked me for her daughter, PRK or LASIK, fear of the flap. And, honestly, the technology is so good in making flaps and the architecture is so good that, these things that we talked about for so many years, stria, flap dislocations, all these problems, they just are incredibly rare, incredibly rare. So you got to keep that in mind.
So I'm going to finish on that thought on this one, but here's why. To get back to your point, Dr. Siddiqui and I saw a patient 3 weeks ago who fell down on a Sunday. We were called by their cataract surgeon on a Thursday for the patient to come in, and they were thinking about coming in next week. And I was like, no, I think the iris is prolapsing out of the wound. And we were like, and she's had vision correction surgery. So a LASIK flap, a subsequent cataract surgery, and iris is prolapsing out of the wound. But guess which wound? The LASIK flap wasn't dislodged. It was the corneal incision that actually lost the integrity first. And so to Andy's point, a femtosecond flap with inverted architecture is unbelievably stable. It's the cornea incision from a cataract procedure done by a blade that likely was the weaker of the points. And so and I'm not saying that this was unbelievably rare. I think I've seen this once in 25 years now, but it can happen. And so, that does speak volumes as to the stability of a femtoflap.
How far post-op cataract surgery was she? Or was this patient?
10 years.
10 years?
Yeah.
Oh my God.
Yes.
Time. It's surprising. Yeah.
Oh, this speaks to the importance of having balance, okay? Don't run into things. How much more time do we have? Do we have time for one more case?
One more.
Okay, in honor of Dr. Solomon, I'm going to pick his favorite case because he's been our fearless leader in developing this conference. So from conception to this, and you get to culminate it with very high hyperopia, please. So when we have this patient, perfect. Thank you so much. All right, so this is a 47-year-old male, right? So typically when we're thinking about what are our options open to us for 47, it's kind of like borderline for refractive lens exchange depending on the situation, right? So he's a soccer coach, used to be a semi-pro, very active person, also a marathon runner. But look at that prescription. What the heck? It's plus 12. Huh?
His eyeball's very short.
I know, not the shortest ever, actually. And his anterior chamber was actually quite large. I was expecting it to be nothing, right? So plus 12. This guy has been marathon running with plus 12. Okay. And the greatest personality. And then he's Irish, so he says everything with an Irish accent. It's so beautiful. So what do you do? What do you do with this patient that has such a high amount of hyperopia? What are your considerations for having a relatively younger age, and do you take into account what you can do in terms of overall quality of life? How does amblyopia play into that? Dr. Solomon or anybody?
Yeah.
That's for you.
That's for me. No, I know what happened. I know what we did.
Me too.
Sonny, yeah, you know.
I'm just going to say, I'm worried about choroidals in the short eye.
Yeah. So you explain that. Yeah. What does that mean?
So with such a small eye, and you're going to open it up, and you're going to have everything kind of come forward from the back. And so you can get some hemorrhagic choroidals or effusion choroidals, and suddenly there's less space in the eye, and then they're going to have blurry vision until the corneals go away with increased pressure.
So it's that the belief is that it's the change in intraocular pressure. You make an incision, the intraocular pressure drops precipitously over a short period of time, and you can get a choroidal effusion or a potential hemorrhage in that space. And there are things you can do to mitigate that, like acetazolamide or some other medications you can provide. We thought about that. And so the presumption is if we're going to make these incisions, one, we're going to make sure we fill the eye, we deepen the eye in the process. And I'd be very candid with you. If we thought, and I checked to see if he would dilate, because if I knew he wasn't going to dilate and I'm playing around with the iris and I wasn't going to be able to get in and out quickly, I didn't want to run into trouble. So we thought about all of that. You're 100% right. Does the amblyopia change your management here?
I probably wouldn't have put a multifocal lens. I may have used like a monofocal plus lens.
In both eyes, or
just the amblyopic eye? I'd probably put a multifocal lens in the dominant eye that's not amblyopic, and like a monofocal plus in the amblyyopic eye.
Dr. Siddiqui, would you do a pinhole optic in the amblyopic end?
Depends on the degree of amblyopia, I would say, but probably not. I would probably keep it simple in this case. Yeah.
So he's like 20/50.
Yeah.
Do you think the pinhole optics has anything, it would impact him at all in terms of all of his sports?
I think it could potentially, worsen his quality of vision. So I would just stay away from that altogether. I'd probably stick with monofocal in this eye.
Very nice. Cool. All right. So what would Dr. Solomon do? He actually found it was actually kind of hard finding that IOL that could correct the most of the prescription with one shot. Right. So he did find this IOL. So he did the multifocal in the left eye, the non-amblyopic eye, and just like Dr. Gohl and Dr. Siddiqui were talking about, staying away from multifocality in the amblyopic eye, mainly because amblyopic eyes have decreased contrast sensitivity already, and then if you pair that up with a multifocal that does have some slight decreased contrast sensitivity. Is your brother gone?
Yeah, he's gone.
Okay, good. So now we have a newer version of PanOptix Pro that has that has more light transmission, so lesser decrease in contrast sensitivity. But still, you don't want to pair those together because then you might end up with lesser quality of vision. So,
can we pause for 2 seconds? So he's a +4. He's more than that, +5. If you were a +2, would you consider a hyperopic enhancement, hyperopic LASIK enhancement?
+2, I might do LASIK. I might, but I would with that. And then did you consider the Aspire lens on the right eye?
No, because we needed this sill, and I don't know if it goes much higher than that. We were limited based on power.
I would do LASIK on that.
You would? +5?
Yeah.
Okay.
If I had, it's not ideal, but
if that's all you had.
I used to do that a lot, and it wasn't.
+5 on top.
Oh, I don't have his case.
We're going to get, you're going to debulk that. You're going to end up with a patient who's really close to plano. They might not.
That's actually where he's going to end up.
Yeah.
Okay.
Yeah.
So this is the discussion that we had throughout all of this, is like, how do we approach this? And also, this is before we got started. The answer may be nothing. We're not going to do anything here. I don't think it makes sense, but I'm sorry. Go right ahead.
Yeah, so then we have more fun with this, right? So why stop there when you can have more fun? So this patient actually does really well. He stabilizes by about 2 months, and then we're going to get ready for it. He wants to go for it. Go for it all, right? And so we're going to do, Dr. Solomon's going to do a piggyback IOL. Okay. So Dr. Solomon, can you explain to us what a piggyback is? Why would you choose an LAL for this? Why doesn't the manifest have to be exactly perfect before we get ready for that?
Yeah, nice.
And why not do LASIK enhancement instead?
Yeah, so I think what Sonny was alluding to was if you're going to put in a multifocal lens and then you're going to put a hyperopic correction on top of the multifocal lens, as Andy was talking about, the topography and the wavefront profile, the little subtleties of that profile of the laser could make it challenging on top of a multifocal lens for the patient to endure what could be just a drop in contrast, and now you're taking a double dip in the drop of contrast.
And it's only one eye patient, essentially, because he's amblyopic in the other eye.
That's right. And so what we wanted to do was avoid manipulating the cornea or putting in an awkward wavefront profile. And so in our practice in Maryland and as well in Northern Virginia, if there's one machine that you all should have, it's a wavefront analyzer,
yes.
An OPD or a ray trace or something, because it'll really give you an understanding of how the patient uses the light. And so we went ahead and put in a piggyback, which means you put a lens on top of a lens. And so in this case, it was in the sulcus. You could put it in the bag. There are concerns, the major concerns being interlenticular opacity, so you just have to be very careful about the material, which that's another reason we were looking at what was the primary lens so that we didn't encourage any fibrotic changes between the lens, because it's not like yagging a capsule. You got to get the pigment to displace itself, and so
And this is impressive in a short eye, to put a piggyback lens in a high hyper.
Is there any concern with that? I mean,
what's the concern of
Hey, guys.
I want to know.
Hey!
Oh, wait a minute.
Now he's wide open.
Yeah.
Now he's wide open.
What about inflammatory reactions, et cetera?
So, yes, there are those concerns. Had you looked at it, the concern would be, and Jack Holliday did a great article on this, not everybody who is hyperopic has a short axial length as well as the consistent short ACD. It comes in every variation. As Jen pointed out, and it may have been glazed over very quickly, is that although he had a short 19.5 millimeter eye, his ACD was remarkably deep.
Like 2.6.
Yeah, and then when you
after
take
this,
the
it was like
lens
4
out,
something.
which is typically 4 to 5 millimeters, it falls posterior, and then we gained even more space to put our lens in. And so we were able to then piggyback in the sulcus with an adjustable lens.
Yeah, that ACD actually gets really, really deep that the Pentacam oftentimes won't even be able to detect it. So then it just comes up as blink.
Yeah.
Okay. So I would say, so we did. Dr. Solomon did a piggyback with a light adjustable lens, and so we follow him. I'm just going to skip through this since we don't have a lot of time. Actually, this is really cool because I get really excited when I can see depth in the eye. So this is going to look at the right and left eye, and then we'll go a little bit zoomed in. You can actually, if you're concentrating on it, you can tell the depth in there. So the one with the broader haptic, and then the 3 little dots there for the toric markings, that's going to be for the right eye, that toric toric lens that we put in, and then the piggyback is going to have that kind of slimmer haptic there. And then in the left eye, you can see the multiple concentric rings that indicate that multifocal lens, and then of course the slimmer haptics being his light adjustable lens. We run through a bunch of treatments. This patient gets to be, at the very end, he's plano in his right eye, seeing 20/50, which was his best corrected because of amblyopia, and he gets down to like plus 75, plus 50 around there, and he's happy as can be. This guy is he's so appreciative of what was done.
That's amazing.
And he has such good understanding that it's not just his acuity. He says, and it's just so brilliant, he's like, every single aspect of my vision is so much better. Even driving, I'm so much more confident. Playing sports, I can see things so much better. It's just a very appreciative patient. So he's, and I'm sorry that he graduated because we had so much fun with him every time he came in.
We did, and I would just say, because I see the team from the HSVP, Holzman Solomon Vision, and HLV in the back. And I know, because we've talked about it, and I wish we could have talked more about this. But when he would come in at his last, you'd think he'd be like, I just am ready to go home. I'm tired of seeing you all. We've done now 2 surgeries in each eye. Can we just be done? And in truth, he's certainly very appreciative of his vision. But what he says over and over again when we see him is, I just can't tell you how great your team is here. They've been so good to me from start to finish. And again, that sounds, I guess, certainly quite braggadocious about it, but there's a lot of effort that goes into making the process as easy and as straightforward. And that makes me more, I guess, happy than anything else, is that the experience is what made this all a reality. So, yeah, thank you. That is a good case.
Cool.
Yeah. Cool.
Great. Thank you, Dr. Solomon, for thinking of this idea and have this. I know we're not the easiest people to work with. We're like herding cats, right? But he was able to get us to all commit to this and have a great meeting. So very good job on that. Thank you.
Well,